Hi Ninja Nerds, in this video we're going to be talking about the stages of labor. If you like this video, make sure to give it a thumbs up, comment down below, and don't forget to subscribe. Check out ninjanerd.org where we have all of our illustration notes and drawings for you guys to check out as well. So let's get into it. With the stages of labor, we're going to specifically be talking about when mom is in her early term to late term. So we are talking about a client here who is in the full-on stages of labor, and how do they start? What's going to indicate to us that our patient is in labor. So typically there is either the bloody show where we lose our mucus plug, or we have our water breaking, which is our rupture of membranes, or mom has the indication of her contractions starting. And whether or not those are true labor contractions or false labor contractions, we will talk about that in a minute. But I wanted to go over really quickly what really starts the delivery of our stages of labor. How do we go from our delivery of the fetus to the placenta to being out of labor? So the beginning, or our start of labor, is our uterine contractions and our cervical changes. And do you remember what those indications are of the uterine contractions, which is our true labor? It's usually those three things: the increase in our frequency, so they're occurring more often, increase in duration, which they're lasting longer, and they're becoming regular. So our contractions are going to increase in their frequency, happening more often, increase in the duration, lasting a longer time, and they're going to be happening more often in a regular pattern. And then what are our cervical changes? Do you remember what we talked about in our previous videos about the changes that happen to the cervix that indicate that we are indeed in true labor? There is effacement, which is our thinning of our cervix. So our cervix eventually becomes thinner and starts to thin out here. And then we also have our dilation, which is then the opening, right? So now our cervical os is maybe going from 1 centimeter all the way to 10, or right there is maybe about 3 centimeters, but you get the point that it's increasing in dilation. So throughout this entire process of the stages of labor with our client and with our patient, we're going to want to continuously assess them. And this is what we're going to be doing kind of the whole time. So with our nursing assessment, when our patient comes in, they're in hopefully the earliest stage of labor that you're going to be seeing them in, and then from there advancing through those stages. So this time is usually the easiest time to orient our client and talk to them about what's going on, tell them what the unit looks like, what the process is going to be like through here, and do our teaching and our talking here, because this is the most coherent or most at education that our patient is going to be. They're going to be more likely to understand what you're talking about and teaching them in this process. When we do get them into our facility, we want to maybe review the birth plan for them. So you want to talk to them about what their plans are for their birth. Are they going to want an epidural? Do they not want an epidural? Who do they want in the room? Who do they don't want in the room? And then also what kind of care they've had through their antepartum. We also want to start getting them on the monitor, monitoring maternal and fetal vital signs, and then also try to lay down what their contraction pattern is at that time and the status of their amniotic membranes. Did they have a rupture of membranes? If they did, we're going to document and talk about that with them, or if they didn't, and then we're going to continually assess them through this entire labor. And you're probably wondering, well, how labor starts just all of a sudden, but what is that process? And there's a little process here that I drew out for you guys to kind of understand in a nutshell what is going on. So baby is going to be pressing on the cervix and causing the cervix to either stretch or pull or efface and dilate. Because of that head being engaged, or maybe it's a foot, maybe it's a shoulder, maybe it's a butt, but they're all pushing on the cervix. When that cervix stretches, it sends a signal to the hypothalamus and the posterior pituitary gland saying, hey, there's some stretching in the cervix. Because of that process, it releases oxytocin. Oxytocin is then released. It causes the uterus to contract. And when we have that contracting, we're making baby push down into further down to our stations. And because of that, baby's head is then continually contracting on this cervix. And we have this positive feedback right here. Also, when all this is occurring, placenta is also releasing some prostaglandins, and those prostaglandins are also telling the uterus to contract as well, which is again pushing on, telling baby to go down, and as baby pushes down into the cervix stretches, and we keep having this release of oxytocin. So this is the starting portion if we are in true labor to start our stages of labor. So let's go in and talk about the first stage, stage 1 of labor. Now our patient is in stage 1, and we're going to be talking about all the stages of labor, stage 1, 2, 3, and 4. But you're going to notice that right behind me there are multiple phases to stage 1. So stage 1, if you didn't know, has 3 phases. There's latent, active, and transition. And if you're like me and you're like, oh great, there's not only stages, but there's phases, and now I have to remember more stuff. I always remember that latent just starts with LAT, which gives me the orientation of these 3, latent, active, and transition. So the goal of stage 1 is to complete the dilation and effacement of the cervix. What we're trying to do is open up that cervix and thin it out so that we have a nice big opening for baby to come on out. So within the latent phase, which is the first phase of stage 1, we're going to be focusing on what's going on with mom and how mom is feeling. So we have the longest phase, and this is usually the phase where we can still talk and breathe normally, carry conversations, walk around. These are the ones, the contractions and the dilation and effacement that is going to be simplest or the most mild. So what we're looking at here is mom's probably coming into the hospital. We're going to do some Leopold maneuvers so we can get our external fetal monitor on. So we're going to check where baby's back is, feel where baby's head is. We're going to place our IV if mom is okay with that and get some blood work drawn. We want to be checking, hematocrit and hemoglobins, check those baseline levels, see what their type and screen is of their blood in case we have to administer some blood later. We also want to get some baseline labs or anything else that we might need for them. We want to get our paperwork out of the way. So this is the phase where if we're going to be doing any type of teaching, any type of paperwork that needs to get done for any type of procedures we might have, we want to fill those out now. Do our complete head to toe, and then get our status on our membranes. Did we have rupture of membranes? If we did, we're going to check with our paper. If mom's not sure, we'll check with our nitrazine paper. If not, or we're not sure, then we can also validate with the nitrazine paper. And if it did, and mom did notice it, we're going to ask what was the color, was there an odor, what was the amount, just so we can get an idea and document all of that. But the biggest indicator of our latent phase is where we are with our contractions and our effacement and dilation. Within our contractions, and this is the big NCLEX thing right here, is the latent phase has the irregular contractions. This is the beginning of labor, so mom really might not notice that she is in labor. She might think, oh, that was just, a random contraction that I'm having. It wasn't really true labor. So they're going to be irregular, these contractions. They're going to last they're going to be in anywhere from 5 to 30 minutes. So they might be as often as 5 minutes, or there might be a span of 30 minutes in between each contraction, and they're going to last around 30 seconds. The effacement is going to be from 0 to 30%. So we're thinning at that 0 to 30%, and our dilation is going to be from 0 to 30. So remember, our cervix is trying to thin. So you can see here, as we progress from latent all the way down through active into transition, we're going to be trying to thin and dilate. So you can see the difference here. Now we're going to move into active phase, and this is where our patient is going to need some more comfort and coaching. This is where we're going to realize, ooh, I think I'm actually having contractions now. I can feel them. They're a lot more moderate in pain. We can feel them. So the comfort and coaching of how we're going to be breathing through these contractions, how we're going to maybe reposition, dim the lights, play some calming music, and encourage our patient to void every 2 hours in order to keep that bladder nice and empty. We want to make sure that we are also talking to our patient if they're feeling a lot of pain, that if they would like an epidural, this is kind of the phase or the area that we would put that epidural in, because we're still able to control our contraction, control our body and our breathing, because once we get past active into transition, they're a lot stronger, and it's kind of hard to sit still for an epidural to go in. So our contractions in the active phase are going to be regular. They're going to be roughly occurring every 3 to 5 minutes now, and they're going to have a duration of about 1 minute. And this is where our effacement is going to be 30 to 80%, and our dilation is 4 to 7. So we're getting ready to have baby, but we're not quite there. And as we transition into transition phase, this is where we're going to start feeling that pelvic and rectum pressure. This is where we're going to feel the urge to push or bear down. Sometimes this is where we may think we have to take a bowel movement, we got to go to the bathroom, but That may or may not happen, but we also may be pushing for a baby. And we don't want to push until we're at 10 centimeters, because if we push before 10 centimeters, we are going to maybe cause some trauma to that area. The cervix is going to get angry because we're going to be pushing really hard and it might swell. And when that swelling occurs, baby's not going to pass through as easily as we would like to. Because of this, the client's going to be restless, sweating, hiccuping, nausea and vomiting, in a lot of pain. So we want to encourage them to stay calm, support them through the breathing, through the contractions, because these contractions are going to be strong. They're going to be super, super strong. They're going to be super, super painful because we are moving now in through our labor. They're going to be occurring every 30 seconds to 2 minutes, and they're going to be lasting around 60 to 90 seconds. If you're looking at this, you're like, wait a minute, how can they be occurring every 30 to 2 minutes, but lasting almost a minute to a minute and a half, or 60 to 90 seconds? They will overlap. As one contraction is starting to fall off, another one might start right back up. And that's how we know we're getting really close to baby. 80 to 100% of our effacement, and then 8 to 10 centimeters on our dilation. And once we have reached our 100% effacement and our 10 centimeters dilated, we are now ready to push and to get baby out. So let's move into stage 2. And now we're on to stage 2. So now we are getting ready to have baby. So we have complete cervical dilation, or if you assess mom, you may see crowning or the baby's head right there, and we are ready to deliver the fetus. So again, this is where it's really important to coach the client and encourage them. You want to make sure that they are pushing when they feel contractions and resting when there isn't a contraction. And if our patient did have an epidural, they may not be able to feel the contraction. So this is when we want to really coach them through, okay, a contraction is coming. I'm going to need you to push. And then time to rest. We got to breathe and get our rest in, because labor sometimes can take a long time and we don't want mom getting tired. So with this, we also want to try to get that comfort going for mom. So we want to either use a cold compress for the head or the back of the neck, and warm compresses down in the perineum to allow everything to relax down there. We want to assist in positioning, so be able to get them in whatever delivery position they would prefer, and then also get the partner involved that is there, because we want to make sure that we are getting mom comfortable and also building that bonding if we can. And then we also are going to have to ask mom if there is an option for an episiotomy, or if you know what this is when we maybe aren't able to get baby out quite. It's a lot of stretching going on, and in order to prevent a tear, we may do a small incision in the perineum. So we'll do an incision in the perineum, and that's going to allow just a little small incision to allow baby's head to pass through and be able to have baby. So then baby is delivered, baby is out, and now we're going to move into stage 3. Now that baby has been delivered, we are going to move into stage 3. Baby's out, and it's now time to deliver the placenta. So don't get confused that baby is out and labor is over. We still have to have the placenta come out as well. Because remember, if we retain placental fragments or the placenta, what can happen is we are never going to have our uterus contract back down to its original size. So that will keep that exposure of hemorrhage or bleeding out. So we need to deliver the placenta. Baby is born, and we want to perform our APGARs of 1 in 5 minutes, and we want to promote that skin to skin, dry baby off, get baby comfortable, get baby warm, put them on our mom, and then be able to move forward with focusing on mom getting that placenta out. So we are going to be looking for certain signs that are telling us that our placenta is separating from the uterus, because remember, it is adhered onto the uterine wall, and it's going to have to separate in order to come out. So some signs of separation from the uterus are a couple things. You want to imagine, right, this uterus here and the placenta are going to start to separate, right? And as they separate, it's a tearing. I kind of picture it as like a scab. When you pick a scab off, you're like breaking all those little vessels in there. So as you pull off the placenta, you're going to have some separation. So the first thing that's going to happen is that umbilical cord all of a sudden is going to lengthen, right? It's going to separate from the uterus and it's going to lengthen. You're going to see it all of a sudden lengthen from mom. Because of that separation and that pulling off, we're going to have a gush of blood. So we're going to have the elongating of the umbilical cord, a gush of blood, and then we're going to have the fundus start contracting. You're going to feel a little bit more contractions as we're trying to push that placenta out. When this all is happening, we're going to say, yay, the placenta is delivered. But there is something we need to do before the placenta is delivered. When baby is out, once baby is out, Baby is out. We want to think about clamping after 1 minute, right? We're going to place 2 clamps on our umbilical cord. So baby is out, we're clamping the umbilical cord, we're trying to get placenta delivered, placenta comes out, and now we are focusing more on the aftercare of labor. So we already have our placenta out. We are going to cleanse the perineal area, place some ice packs. If there was an episiotomy performed, we want to make sure that we are getting the suture, or if there were some tears, we are getting that all sutured up nice and clean. We also maybe want to think about starting Pitocin so that we can have our uterus contract back down and then decrease our chances of hemorrhage, postpartum hemorrhage. We also want to assess our umbilical cord. Remember, when we are looking at the opening of our umbilical cord where we cut it, we're looking to make sure there are 2 umbilical arteries and 1 umbilical vein, making sure that we have the appropriate vessels in there. We also want to make sure that we are assessing our placenta. Our placenta has 2 sides. Remember, we have dirty Duncan, which is the underside that ripped away from the uterus, which is the maternal side. And then we have the shiny Schultz, which is the part that is where the umbilical cord comes, and it's on the baby because the baby's new and happy and shiny. So once we do all this assessing and we're documenting through all of this, we are now going to move into stage 4, which is the care at the end of labor. We're not quite done with labor. We still got to keep an eye on mom for the next 2 hours. So let's talk about stage 4. Baby is out, placenta is out, and now we need to take care of stage 4. So stage 4 is now, once the placenta is out, we have about 2 hours after to keep an eye on mom. And the biggest things that we're going to be focusing on is that postpartum hemorrhage, what's going on with mom. So the maternal vital signs, we want to make sure that we are keeping an eye on our vital signs, and particularly blood loss. So we're going to be focusing on our blood pressure and our pulse. And we want to make sure there's 2 things we're basically looking for. Are they hypovolemic? Or if they had any other problems, we might be thinking, are they having preeclampsia, right? If they had some preeclampsia prior to labor, they could still be in that range for the preeclampsia. So we're keeping an eye on their blood pressure and their pulse. And we're also going to be keeping an eye on their lochia, which is every 15 minutes. We're going to be assessing that bleeding. And what we're looking at is we're going to be looking at that pad and seeing if that pad is going from a heavy to moderate all the way down to hopefully a light, okay, as we progress from labor, from placenta being out and on from labor. So what we're looking at here is it should be decreasing over time. Our bleeding should be decreasing over time. Our vital signs should be steady. And when we are assessing our fundus, it should feel nice and firm. If it feels boggy, we're gonna think there's a couple things I can do. Big end question here. You assess your postpartum patient and all of a sudden you're feeling a boggy fundus. What are you going to do? You're going to massage the fundus, right? We're going to be using our hands to place here and here on either side of our uterus, and we're going to try to massage the fundus, right? Try to make it shrink back down, because what we want to do is have this contract all the way back down into its small pre-baby shape, right? If it's not, or if the fundus still feels a little boggy or mushy to you, you maybe want to think about some medications like oxytocin or oxytocin, those medications that are going to increase that uterine contraction, so help that uterus to shrink back down. We also want to be looking at the urinary output of our patient, making sure that we are preventing distension of the bladder. We don't want the bladder to be distended because it may cause some other issues within our abdomen. We want to facilitate the family bonding to the baby, so we want to make sure we're doing skin to skin. We want to make sure that we are increasing with the feeding and getting that bonding experience, whether it's breastfeeding or bottle feeding, so that we are building that bonding moment with baby. If mom had an episiotomy or had some tearing and there was a laceration, you want to make sure you're assessing that area and making sure you're providing care so there's no infection rate there going on. And then we also want to encourage that we have our client eat, sleep, and urinate. The eating and sleeping is a big part. Sleep when baby sleeps, and try to eat as well, because there might have been a really long labor. Labor might have been over 20 hours in total. So we want to make sure that we're keeping an eye on our client and making sure that they are getting that rest and that energy back that they had. And that is it. That is the 4 stages of labor. I hope it made sense. I hope you got something from this video. If you did and you liked it, make sure to hit that like, comment down below, and subscribe. And as always, until next time.